talking next. She will be talking on the tuberculosis and lookalikes in intraocular diseases. Dr. Shefali is doing her fellowship with Dr. Santosh Unava sir at Center for Sight.
A very good evening, everyone. Thank you so much, Dr. Sumit, for my mentors are here. So it's really a matter of privilege for me. So today I'll be talking on intraocular tuberculosis and the lookalikes. Well, it's a huge topic, so I'll try to keep it very practical and clinical. I have no financial interests. So I hope, yeah. So, tuberculosis, as we know, is an infectious disease with protean manifestations. It is caused by Mycobacterium tuberculosis, pathologically characterized by a granuloma formation. It predominantly affects the lungs, but it has extra pulmonary manifestations. And why the TB? Because we have it is actually a global emergency. It is the most common cause of morbidity and mortality worldwide, and the annual worldwide incidence is on the rise, and it is 8.7 million, as we can see on the WHO site. And on the Indian website also, it was reported as 21.4 lakh TB cases were notified in India in 2021, which was 18% higher than 2020. So definitely India is a TB endemic country. Post-HIV era, the extrapulmonary tuberculosis is on the rise, and from the blood, it can spread to any part of the eye, as we can see in the diagram here. Some studies have actually, they have gone on to see the patients, like 10,000 patients were reviewed, and it was found that 1.4% had ocular tuberculosis. In India, Dr. Jyotirmay Biswas and group from Shankar Nethralaya, they have seen amongst 1,005 patients with active TB were reviewed, and it was found that 1.39% had ocular tuberculosis. Also, out of 1,273 uveitis patients, 0.39% were ocular TB. So TB can have various manifestations like anterior uveitis, intermediate posterior uveitis, retinitis, choroiditis, neuroretinitis, endophthalmitis, and panophthalmitis. So if a patient like this presents with hypopyon, posterior synechiae, mutton fat KPs, cope nodules or granulomatous nodules on the iris, definitely it's a referral to our uvea friends. Also, conditions like this, like Eales disease, serpiginous choroiditis, vasculitis, these cases go to retina consultants. So, where does our role as an ocular oncologist comes in? Our role comes in when a case like this is referred, and when we see an isolated lesion like this, which can be a mimic of a lot of other choroidal lesions that we see in the eye. It is important to recognize the granulomas and differentiate it from other conditions. So, I'll be taking you through the same in the slides to follow. These are the various mimics that we can get of the choroidal granuloma. So choroidal involvement happens through hematogenous spread of the infection from the blood to the choroid, as in any other systemic disease. And hence, we have a long list of differential diagnoses of amelanotic choroidal lesions like leiomyoma, posterior scleritis, granulomas, METs, amelanotic melanoma, osteoma, hemangioma, and choroidal detachments. So what I would like to say is you should start always from the beginning. History can give us many clues. Well, if a person has systemic TB, of course, if we are looking at a choroidal lesion, we should think in that terms. If a patient has a systemic cancer history, if we are looking at a choroidal lesion, we should actually think about a choroidal METs. Second, examine the patient and not just the eye. So you have to see the lymph nodes, the systemic evaluation, and the other things that we have to see in this, and not just the eyes that we are examining in the patient. Before you peep into the eye, definitely do gonioscopy, intraocular pressure measurement, the anterior segment evaluation, and then only dilate the patient. When we dilate, as our mentors have taught us, we should look at the location of the tumor, multifocality, the color of the tumor, the size, the shape, the surrounding SRF, and the secondary changes that the tumor has caused in the surface. And then we investigate further with B scan, autofluorescence, fluorescein fundus angiography, ICG, OCT, or a PET scan. So a lesion like this, if we go systematically, definitely we can clinch the diagnosis and treat the patient appropriately. So if we see a lesion like this, which is a yellow elevated choroidal lesion with surrounding SRF, it can be single, it can be multiple, it can have vitritis associated. It is hyperfluorescent on AF, and on B scan, it is like a dome-shaped mass with medium to high internal reflectivity. So this can point us towards choroidal granuloma. When we do an OCT, on OCT it shows an elevated choroidal lesion with surrounding SRF, and FFA will show hypo or late hyperfluorescence with staining. Another case is like a case like this, where there's a yellow tan color lesion with subtle pigmentation. Well, in such cases, we should think about choroidal melanoma or amelanotic melanoma, and definitely remember the mnemonic: thickness, fluid, the surface, the orange pigment, and the other manifestations that we have been taught for the choroidal melanoma. When we see the B scan, if we see a collar stud appearance, of course, it's a quite characteristic feature of choroidal melanoma on a B scan. So it can be dome-shaped with hyperreflective lesion, which has a moderate to low internal reflectivity. On OCT, there'll be a gentle dome-shaped lesion with smooth surface topography with subretinal fluid. It can have shaggy photoreceptors, disruption of the outer retinal layers, and complete loss of choriocapillaries. What about a very subtle choroidal lesion like this? The patient was symptomatic and was complaining of an inferotemporal scotoma. So there was a lesion in the choroid. When we do an autofluorescence, it is fluorescent. And when we do a B scan, there's a very subtle choroidal lesion, which is echogenic. It can be associated with secondary retinal detachment. It has a lower height to base ratio and high internal reflectivity. And also the patient gave us a history of systemic breast cancer, and he was under treatment. So of course, we are looking at choroidal mets. So this is another differential that you should keep in mind. This is another picture of a choroidal metastasis. When we do an OCT, an EDI OCT, the plateau, it has a plateau surface, shaggy photoreceptors, and subretinal fluid. It will have a typical irregular, lumpy, bumpy anterior contour with anterior compression of the overlying choriocapillaries and posterior shadowing. What about a lesion like this? So this we are talking about choroidal lymphoma. On OCT, it has a typical undulating cystic tumor surface with overlying subretinal fluid. Another case, so if we look at an orange-red lesion like this, and if we look at the patient who appears like this, of course, we are looking at choroidal hemangioma. So you have to measure the intraocular pressure, you have to see the anterior segments for other findings of Sturge-Weber. And on B scan, it will show acoustic solidity with high internal reflectivity, diffuse hemangioma, which can show diffuse marked thickening of the choroid, whereas the circumscribed version can show or appear as a plecoid or an oval mass. On fluorescein angiography, early lacy mild hyperfluorescence in the pre-arterial or the early arterial phase is seen, and diffuse intense hyperfluorescence in the late phase is seen. OCT will show us a smooth, gentle sloping of the choroidal mass with overlying SRF, and expansion of the medium and the large size choroidal vessel, and no compression of choriocapillaries will be seen in the OCT. What about a lesion like this? It's a 40-year-old female, absolutely healthy, and we see an orange-red lesion inside the when we see the fundus. And the B scan appears like this. Any guesses? Yeah, so what we are looking at is a choroidal osteoma, and it is the B scan is showing like a plaque-like lesion, echogenic foci, and acoustic shadowing. So this is another differential that we should keep in mind. Osteoma will have an early patchy hyperfluorescence with late diffuse staining. If CMVM is present in osteoma, which it can have, there will be leakage seen in the fluorescein angiography in the late stages. On OCT, the RPE and external retinal layers abnormality will be found, and if macular neovascularization is seen, SRF will be present. Another slide that I would want to leave you with is this, which is another differential, which is VPRT, vasoproliferative retinal tumors. So as we see, choroidal lesions can be confusing. If we keep a systematic approach to the case, it can help us narrow down our differentials, and examining the patient as a whole and systemic evaluation can help us clinch the diagnosis. So once we have made, just a word about the treatment of tuberculosis, if we have made a diagnosis of tuberculosis, we can go about Montus testing or quantiferon TB gold test, which is another screening test, a chest radiograph, or a AIB microscopy of the specimen. Mycobacterial culture of the specimen is the definitive diagnosis, or isoniazid diagnostic testing. Without microbiological confirmation, which can be challenging to obtain, diagnosis of intraocular TB mostly remains empiric, and the response of ATT may be the only definitive evidence of TB, and especially in a country like India, we should be in contact with our internist friends to treat such patients. The treatment comprises of HRZE and 4 to 7 months of HNR. If there's a paradoxical worsening on starting of ATT, we should keep the role of corticosteroids in mind. Also, while starting an anti-tubercular treatment, a role of an ophthalmologist is important, because most of the drugs can cause optic neuropathy, decrease in visual acuity and color vision, and centrocecal scotoma. So baseline examination of the eye in detail is absolutely essential. Also, a word about collaborative ocular tuberculosis studies spearheaded by the PGI group. It can help us direct in the treatment of these patients. And the results can be very gratifying. Thank you so much for your patient listening.
Thank you, Dr. Shefali. That was really good talk on choroidal granuloma and other lesions. So, just for the benefit of everyone, if you see a lesion which is within your mind, the primary differential diagnosis is of choroidal granuloma, and you had written the area of investigation. So, what all investigations that you will advise to this patient? Because many times it becomes difficult to convince a chest physician that we need to start on AKT, and they sometimes need a microbiological diagnosis, which of course we cannot do in such cases. So what all investigation? Of course, the court study.
Systemic tuberculosis.
Systemic tuberculosis.
A Montu's test and quantiferon gold test will be a screening test, and high resolution CT of the chest can be done, and that is the screening test that can be done. But the confirmatory thing comes only if pulmonary TB is diagnosed and we see a specimen on culture sensitivity. Otherwise, it is an empiric diagnosis, and we start off with the AKT treatment.
So we do a baseline investigation. When you see such a lesion, you can do a baseline investigation of doing a Montauk test, TB Gold test, of course HRCT or chest X-ray, and then refer to physician with your empirical diagnosis that this could be choroidal granuloma. Of course, you do a mandatory ocular investigations and then you send it across. Thank you so much, Dr. Shefali. So next we have Dr. Fairuz ma'am with us. She has done her oculoplasty, ocular oncology training from LV Prasad Eye Institute and also at the Wills Eye Institute. Presently, she is working in Bangalore in her own center. She is also a member of scientific committee, and she will be presenting few interesting cases in ocular oncology. Over to you, ma'am.
Thank you, Sumit. Thank you, Mritika, for this, including me in this session. Seems very, very interesting with this promising young ocular oncologist that we have in India at this point of time. And yeah, is it on? Yeah. So a few interesting cases, and that's what I understood, right? Like just cases which is, yeah, interesting. Connection. वहाँ पे कनेक्ट करना है? Do we have any questions for the previous speakers? Probably, we can have a discussion during the meantime.
So do any of you have any questions? I think we have time till the slides are set up. So what are the common conditions that you encounter in your clinics, ocular oncology related conditions? Anybody? How many of you are retina specialists here? All right. So we have 2 here.
Is it, any cases where you have a dilemma that it could be a inflammation or a neoplasia? Most commonly, you.
We have our UVA colleagues send us cases to rule out vitreoretinal lymphoma. I think that's a very big masquerade, and it usually comes to us at a very late stage when they've tried everything, and then they say that, okay, this is not responding, this is not a uveitic condition, and unfortunately, most of the times, like I said, they come very late to us. So one thing that I keep trying to sensitize that, send it to us once, let us have a look at how the vitreous looks.
So Dr. Feroz is going to take us through a really interesting topic on 50 shades of white.
Right. Yeah. Not gray, but white. So because in my practice, I do a lot of retinoblastoma, and there are certain situations where there is a clinical dilemma, whether it's the white due to retinoblastoma or whether it's a white due to something else. I'm sure Mritika took you through a lot of differential diagnosis today. So this is basically a case-based, two very interesting cases that I came across, and these are my affiliation. I have no financial disclosures or interest. So this was a 3-month-old child, a female child with a birth weight of 2.8 kg, not premature, full term, who presented and who was referred as a case of retinoblastoma and with a history of white reflex for 2 months. So taking you through the case, as you can see here, there is a very stark difference between the right eye and the left eye. And what you see in the left eye is, do we have any postgraduate students here? Any postgraduate student? Yes? Is she a postgraduate student who's walking around? No, she's not. Okay. Are you a fellow? A consultant? Cornea fellow? Right, cornea. Is there something that is it a normal cornea or? Well, white reflex is obvious, right? Yeah. Anything else like being a cornea, a fellow? Is there? Okay, yeah. It is, the pupil is irregular, in fact. I'm being very specific about cornea here.
About the size, maybe? I'm not sure.
Yes,
Is it
about the size. Yes. So you can see there is a, increased diameter, the horizontal diameter of the cornea. This looks like ophthalmic, right, when compared to the other eye. So right from the anterior segment evaluation. So I'm going to take you here. Okay, so this is how the anterior segment evaluation looked like. This is the right eye, which is a normal eye, and the left eye, there is increased in the corneal diameter. And the other things, in fact, there is a little bit of corneal edema also, although Habs striae was not present. And the intraocular pressure was 20 millimeters of mercury. Anterior segment evaluation had ectropia on UVA. Posterior synechiae, as she already mentioned, you can see an irregular pupil over here. Diffuse neovascularization of the iris and angle neovascularization. So what would you do at this point of time? How would you want to go ahead with it? Well, ultrasound B scan was done. Okay, I'm going to show you the MRI of the. So you have definitely a ophthalmic eye there, and this is a T1 weighted image where you have kind of a hypodense lesion, diffuse hypodense lesion over here, and a foci of hyperintensity sitting in the center. Could this be retinoblastoma, a white reflex? What are the other differential diagnoses that you would want to think about at this point of time? Unilateral ophthalmos, white reflex. I'm sure this question goes to Mritika. If you can have a discussion.
Anybody can take the mic here. I think Dr. Sumit went through a number of these conditions. Let's make it a little interactive.
Yeah, let's make it interactive. And this is basically case-based. I'm not going to take you through any theories, very little bit information that I'm going to give you. Shefali, you want to take it really quick? PHPVS, unilateral, yeah.
It's a large eye.
There is a lot of neovascularization. PHPV we generally don't find. So something which is, there is compromise of vascularity of the intraocular contents, right? Yeah. So, well, what do I do next? Okay, so there are certain rare, common and rarest situations. So any patient, well, I didn't do it knowingly, but we do a systemic evaluation for any child, whether it's retinoblastoma, whether it's PHPV, anything, a child presenting with an ocular abnormality when the child is under anesthesia, we do a systemic evaluation. And I did a systemic evaluation, all right? So this is what I found in the systemic evaluation. So you can see this, hyperpigmented patches in the upper arm, it's there in the lower legs, okay, and it's also there diffusely in the trunk along the Balch lines. This is called the Balch lines. And when I went back taking a history from the mother. She said, yes, when the child was born at 1 month, there were a lot of vesiculobullous lesion where the child was taken to the dermatologist, and then it resolved spontaneously, leading to this black lines. I got my diagnosis.
This was not covered by Dr. Sumit.
This was not covered. I'm happy. Right. So I got my diagnosis right there. What is the diagnosis? You are not answering. You are the boss of the boss. You know all the diagnosis. Incontinentia pigmenti. Okay, now what did I do next? Okay, so we all know incontinentia pigmenti is a dominant X-linked disorder, most common in females, and the child had a sister. Okay, so I immediately called the sister and then I examined the sister. So there were dental anomalies in the bigger sister. Okay, she was 6-year-old, and if you can see here, there are faint, patches in the skin of the sister. In fact, the mother and the aunt also had dental anomalies. Although they were from a very poor social background, I couldn't do the gene testing for him. So this was a case of incontinentia pigmenti, which presented as a white reflex, X-linked dominant. There is gene associated with it, which has been discovered, and you can always, for academic purpose and to know exactly the gene, we can always do the genetic testing, most commonly in females. And it is said that if it is in males, it's very, very fatal. Now, what do you mean by fatal? It's a central nervous system involvement. They can have seizures, they can have mental retardation, and even the child can die due to the disease. So it's basically an ectodermal and mesodermal dysplasia. And the various structures which is involved, it's skin, hair, nail, teeth, and bones. Now, there are two criteria, the major criteria and the minor criteria. And the major criteria is the skin lesions. Although it's rare, I just want to, talk a little bit on this. Vesiculobullous to start with, then verrucous, flat hyperpigmented, and then it becomes hypopigmented. So in the baby, we had the stage 3 skin lesion, and the sister, we had the stage 4 skin lesion. All right. And the minor criteria are the dental anomalies, alopecia, nail ridging, and the retinal abnormalities. So 92% of the patients present with the skin abnormalities and 65% with the dental anomalies. So all these patients, when we come across, they come with some amount of complication, whether there is already a white reflex, whether retinal detachment has happened. So this was a very nice paper way back in 1982, when they actually evaluated the child at 1 week and then progressed to 5 weeks. So this is how rapidly the neovascularization of the retina happens. And finally, there is extensive retinal detachment, exudative retinal detachment, NVI, NVG, and then finally the child. Yeah, so in this child, although, it was a painful blind eye, increased IOP. What I did was I in fact enucleated the eyeball and gave a nice artificial eye implant, an artificial eye. So this is about this case. Now, 10-year-old female with a history of pica. Well, you know the diagnosis already. All right. So this was also referred to me as a case of retinoblastoma. In fact, the referral doctor was scared because it's sitting on the optic nerve, and there is obviously a retinoblastoma sitting on the optic nerve is very, very scary for even me, right? So at the look of it, it didn't look like a retinoblastoma for me. Why? There was no feeder vessels. Usually retinoblastoma has this typical feeder vessel which dips into it. Well, it's not there, and there is some amount of exudation which is happening in and around, some amount of vascular, I would say vasculitis, which is happening over here. So I was not convinced with retinoblastoma, and I was not scared. And this was the ultrasound picture, ultrasound B scan, where optic nerve is absolutely fine. There is no invasion. Now, the things that we would think in a child presenting with this optic nerve head lesions, what are the few things that you want to tell me, like in your clinical practice? We spoke about granulomas, Shefali, right? Yeah, tuberculous granuloma, right? Maybe sarcoid. Leukemia, right, in children, optic nerve head infiltration of leukemia in the posterior pole. Anything else? In the history I gave, yeah, it's there. It's looking at you. History of pica in a child.
You can also ask about history of exposure to pets.
Right. History of exposure to pets. Yes, she has cats, dogs, everything at home. But the father was very worried about the fact that she is eating mud. That's what he said. Right. So in my mind, the first differential diagnosis that I kept was toxocariasis. All right. Yeah. So we went ahead doing the serum ELISA, toxocara antibody. It was positive, although the sensitivity is only 78%. Well, in Seoul, South Korea, they also have ELISA for toxocara antigen, the crude antigen of toxocara, where they say that it's 98 positive percent sensitive, although we did the antibody serum ELISA. IgE is something that you want to look for. Along with eosinophilia, it was elevated. Well, I did peripheral blood smear, I did Mantoux test, I did quantiferon gold test, which everything came negative. So this was a case of toxocara granuloma, which was presenting over the optic disc, and it's an atypical presentation. So this child was treated with oral corticosteroids, subtenon, triamcinolone, acetonide. So she came with PL positive, and then she improved, in fact, 6/60 at the end of the treatment. And finally, this was like 6 weeks, and this is after another 6 weeks, 12 weeks, where it has kind of shrunken and the optic disc can be seen, and it has regressed towards the superior papillary. So, well, ocular toxocariasis, we all know that usually it can present in the posterior pole, granuloma in the macular area, peripheral granulomas, nematode endophthalmitis is another thing where the child will present with severe inflammation of the eye, and sometimes atypical presentation like this, which was simulating a retinoblastoma. And it's a zoonosis. This is a cycle. I'm not going into the detail about it. All right. And thank you so very much. Yeah.
Thank you, ma'am. That was there were really nice cases, and of course they are rare too. Any questions, anyone regarding this?
I'm sure you might have come across toxocariasis in your practice. Like, what is a common presentation that you see in retina practice?
Mostly we see peripheral granuloma, and we get referred as FEVR sometimes because they have this falciform fold.
Right.
And a lot of our anterior segment colleagues see the fundus in a limited view, and they say that query FEVR, and they send it to us.
Right.
Some of them have clear vitreous, so it does look like there's nothing in the periphery, but when we look carefully, we can see. And we've seen folds that are radial multiple because there are multiple granules.
Correct. Yeah. I had a child who presented with severe vitritis. Like, the vitreous was filled, again referred as a case of retinoblastoma, although there was no fluffy seeds like retinoblastoma. In fact, we went ahead, took a vitreous biopsy, and then it was proven to be toxocara. That's also quite a rare presentation. Yes, falciform fold. Like when FEVR we talk about, isn't it bilateral usually? Unilateral, it's
FEVR can have a seemingly normal retina on the other side, only on peripheral avascularity can be seen, and when we do an angiogram, it becomes evident.
Correct.
So even not just difference in family members, but different in both the eyes. In fact, one eye can have a total retinal detachment, and the other eye can just have a peripheral avascular,
like an asymmetrical presentation. And you always do an FFA in these patients, right?
Yes. Depending, like if we have a pediatric retinal detachment which is coming really young, then we do a FFA, and then if we don't have a diagnosis, we try to tell them for genetic testing as well, because syndromes are associated with.
Absolutely, yeah. And PHPV is something, or PFV, persistent fetal vasculature, which is unilateral usually.
Yes, but like it was mentioned that in a talk, that now we know that PFV has other eye findings as well. So other eye peripheral avascularity has now been reported not just in 1 or 2 studies, but multiple studies. So it is not just, so earlier we were thinking if we have one eye stalk and other eye avascularity, it is FEVR. It is not like that anymore. And interestingly, PFV is also associated with few genes which are overlapping with
is it?
FEVR.
So
the NDP gene has been implicated in both. And I guess also in Coats disease in animal models or something, I think.
NDP is.
So NDP is a very interesting gene.
Exactly, yeah. Thank you so much. Thanks. Thank you.
Thank you, ma'am. And we'll come to our last talk. It's with Dr. Santosh Onava, sir. So he does not need any introduction. That's a good line to say, because if you want to introduce him, it will take one more session altogether. So I would like to just sum up in a line that whosoever all the speakers that you heard today, all are trained by him. So over to you, sir, for the last talk.
Thank you, Sumit. I'll be taking you over a series of cases showing some of the mimics of intraocular tumors. Well, this is how I always begin my series of mimics of intraocular tumors. This is your routine OPD where everything looks similar, in the middle of which would be hidden something that may be sinister, and that could be a tumor or a malignant tumor. So we have to go behind the mask and see what is real. Like, I'll show you 10 situations where there could be similarities in clinical manifestations or something that is hidden. So if you have a patient with, say, if you're a glaucoma specialist and you have a patient with periocular pigmentation and episcleral pigmentation, is there a possibility of this patient having an intraocular tumor? What do you expect? Suppose you look at the soft palate and you find that there is pigmentation here, you see that? And if you lift his hair and you find hairline pigmentation, what do you expect? This is melanocytosis of the soft palate, which indicates that the patient may have esophageal melanocytosis. And if there is hairline pigmentation, then that could harbour a meningeal melanocytosis, both of which could result in melanoma of the respective areas. Apart from that, when you look at the fundus, if you find asymmetrical fundus pigmentation, that's choroidal melanocytosis or UL melanocytosis. That will also involve the iris and the ciliary body. It may look as severe as this. So these patients should be followed very carefully with ultrasound B scan, and if at all you find that the area of pigmentation is increasing in thickness with some amount of echolucency, then the patient may be developing an early melanoma. So serial B scan monitoring for thickness is important, as well as gonioscopy, because these patients have a tendency to develop peripheral iris melanoma, ciliary body melanoma. Like this patient, this melanoma was never detected until it grew this big, because it was hidden in the ciliary body, and only when it broke through the iris, peripheral iris, and the angle and became visible in the anterior segment was this detected on UBM. So it's a good idea to do a 360-degree UBM whenever you have a patient with nevus aorta, and follow it up at least on an annual basis with a serial UBM and also B scan. Finally, this patient needed enucleation because you know that this patient has a diffuse melanoma all over and the ciliary body melanoma as well, and that's the scleral melanocytosis in the posterior aspect. Then we have a sentinel vessel like this and a cataract. You will not be able to see the fundus readily. So you should actually suspect in a patient who has a sentinel vessel, one single or couple of vessels in a particular set of clock hours, then you should suspect that the patient may have a ciliary body melanoma or a ciliary body lesion. It could even be a benign lesion of the ciliary body, such as leiomyoma, that will also have a sentinel vessel. So unless you do an imaging, you'll not be able to differentiate one from the other. So that kind of a sentinel vessel will always harbinger a ciliary body tumor, and sometimes it may be evident when the patient looks in the extreme direction with the slit lamp angulated in a totally opposite direction, peep through the dilated pupil, you may be able to see the apex of the lesion, but more often than not, you'll need a UBM to detect it. Now, when there is sectoral shallow anterior chamber or a hump like this, shallow anterior chamber would mean uniformly shallow, but whenever you find a couple of humps like that in the periphery, then you're looking at something which is pushing the iris from the periphery, and that could be a cyst. So unless you do imaging again, you will miss this cyst, and you'll not know whether it's a cyst or a solid lesion, and the solid lesion could be a melanoma. So you are mandated to perform UBM in every patient who has a peripheral iris hump, because you'll never know whether it's a melanoma or a cyst. Now here is a unique situation. One of my recent patients who had a iris pigment epithelial cyst. If you thought, okay, it looks clinically like an iris pigment epithelial cyst, and send the patient away, we would have definitely done harm to the patient, because underlying which was a melanoma. You can see a melanoma with a cyst. So that's a double mask, right? And when you do, of course, plaque brachytherapy, size of the melanoma has reduced and continued to regress, and the cyst also started disappearing. So you should never be satisfied with your slit lamp evaluation, and always do imaging in a patient with iris pigment epithelial cyst, wherever the cyst may be. Next set of situations would be unilateral glaucoma in the young. This 30-year-old has had a trabeculectomy already for uncontrolled intraocular pressure. And behind that peripheral iridotomy, you can see something brown now. His trab has failed. He continues to have elevated intraocular pressure. He has correctopia and ectropia nevus, thus the glaucoma specialists are diagnosed with the case of IC syndrome. And he has NVI, which is very atypical for IC syndrome. So whenever a patient has correctopia, ectropia nevus, and neovascularization of the iris, you should suspect melanoma. And this patient indeed had melanoma. You can see following enucleation, you find that that's the scleral flap. Under the scleral flap, there is melanoma. Bleb also has melanoma. So it's become extraocular now because of this inadvertent trabeculectomy. Now, some patients may have a ring melanoma of the iris and trabecular meshwork, and that can also present like glaucoma in a young individual. But what if a patient, young individual, has unilateral glaucoma, but the pupil is nice, round and central, and there is no neovascularization of the iris? Then it's most likely to be a benign tumor such as melanocytoma. Melanocytoma is laden with pigment, and it starts shedding pigment, which gets deposited in the anterior chamber like that, and then that can cause melanocytoma, lytic glaucoma, or trabecular meshwork plugged with this pigment, causing mechanical obstruction of the trabecular meshwork. In granulomatous uveitis, you have a couple of situations. Tapioca melanoma is a malignant tumor which looks like granulomatous uveitis. It may look like this on imaging, and metastasis can also look like granulomatous uveitis. This patient had lung malignancy, bronchogenic carcinoma with iris metastasis, which may look like large iris nodules, which may look like granulomatous uveitis. In hypopyon, there are many situations. If hypopyon in an elderly individual or a child, then you should suspect that there could be an atypical situation, especially in a 70 or 80-year-old patient who has history of alternating constipation and diarrhea, who presents with multiple iris nodules and a yellowish hypopyon. You should suspect that there could be adenocarcinoma of the colon. Whenever a tumor metastasizes into the eye, it will follow its primary characteristics. Adenocarcinoma being a secretory tumor predominantly, it will continue to have this kind of a secretory quality. Those are the metastatic nodules in the iris, and the patient has consequently yellowish hypopyon. This was a 60-year-old male with white eye hypopyon. There is no ciliary congestion or circumcorneal congestion, yet the patient has significant amount of hypopyon, irrespective of the fact that the patient has a fibrin membrane on the anterior lens capsule, which is slightly atypical for this situation. There are no synechia at all. There is no circumcorneal congestion. You should definitely suspect that the patient may have lymphoma, leukemia. It could be any lymphoma, any leukemia, ALL, CML, and AML predominate. Of course, any type of leukemia can present with white eye hypopyon. Whereas in a child, 5-year-old child under treatment by a uvea specialist for about 3 weeks already with topical steroids, has a white hypopyon with a level, and the uvea specialist has not found an intraocular tumor. Why do you think that has happened? With this 7 or 8 millimeter pupil in a 5-year-old child, would you be able to see the fundus well? Of course, you'll be able to see the fundus well, but not the periphery, because you are supposed to do a indented peripheral retinal evaluation, which may not be possible in a clinic. So this child, being 5-year-old, has a peripheral retinal tumor, retinoblastoma, and that can easily be missed unless you do a 360-degree indented peripheral retinal evaluation, and this is retinoblastoma. These are all situations where there is anterior chamber seeding of retinoblastoma, which may look like inflammation. Whereas when there is a heaped up hypopyon with translucent granules, then you may suspect medulloepithelioma. That's how it presents. In fact, about 2/3 of medulloepitheliomas can get missed clinically. They may be diagnosed as glaucoma and cataract and be treated with those intraocular surgeries for cataract and glaucoma, and they may be missed totally by clinical evaluation. In hyphema, if you have a child with recurrent hyphema with the iris architecture obscured by a yellowish lesion, and that picture was taken in the middle of 2 episodes of hyphema, then you should suspect juvenile xanthogranuloma. Of course, clinical confirmation is when you look at these skin lesions, which are quite typical. And when you have a hyphema patient with hyphema with a peripheral pigmented iris lesion, then that could be a melanoma of the iris, which is necrotic, causing hyphema. And this is a 14-year-old child with history of trauma while playing at school, and then she has hyphema which has lasted for almost 30 days now. She's been on oral steroids, tranexamic acid with no relief. There are levels of hyphema, old hyphema, new hyphema. She was referred to a glaucoma specialist for hyphema drainage and trabeculectomy. He did a UBM and he found that iris was thickened at a particular area, particular set of clock hours. So iris thickening should not be there in traumatic hyphema. So we went ahead and did a peripheral blood smear and bone marrow biopsy, both of which were negative. That's because the child was already on a good dose of steroids. And any patient who's on steroids would have the peripheral blood smear rid of abnormal circulating leukocytes, and that's why this was missed. The peripheral blood smear and bone marrow were normal, and iris biopsy confirmed the diagnosis in this patient that the child has AML, and following treatment the child did well. This is a 5-year-old child who has had a history of trauma, and as an evidence of trauma she even has a small lid laceration. You can't deny that the child has had trauma, and there's a full chamber hyphema. They did a B scan, and then they declared that it is vitreous hemorrhage because the cross vector is not passing through the area of interest. That's the area of calcification. So consequently, the child underwent hyphema drainage, and 7 months later, child comes with extraocular extension of retinoblastoma with intracranial extension and regional lymph node metastasis. So whenever you have a child with hyphema, you should pay very careful attention to B scan. And if at all there is any subtle evidence of even bit of calcification, you should do a CT scan, complete the evaluation, and then only go ahead with hyphema drainage if at all it's really warranted. Or if there's a high suspicion of retinoblastoma, you should possibly go ahead with management of retinoblastoma. In situations where there is lens coloboma and retrodental membrane like this, even if the lens is partially cataractous or cataractous, you may not be able to see the rest of the fundus. You should do imaging, because you may be missing a patient with medulloepitheloma. Whenever a patient has zonular coloboma, you should suspect medulloepitheloma. And whenever a patient has vascularized retrolental membrane, then the diagnosis of medulloepitheloma should be very seriously considered. That's because the posterior lens capsule acts as a scaffold. If this is the medulloepitheloma, it kind of travels along the posterior lens capsule, forms a layer of tumor which gets vascularized. So vascularized retrolental membrane can look like a cataract. This patient was from the table of a pediatric ophthalmologist. He was just about to make a clear corneal incision. He fixed the eye here with a forceps, and then he noted that the zonules were missing in this clock hour, and then he found that there was a peripheral tumor right there. So this was medulloepitheloma, and the cataract that this patient had was secondary cataract due to tumor proliferation along the posterior capsule. So this was a posterior subcapsular cataract. Sectoral cataract can also be a manifestation of medulloepitheloma. You can see that this may look like uveitis to you, but you can never miss this vascularized retrolental membrane in a patient with medulloepitheloma. Vitreous is, I think people must have already covered lymphoma, right? Right. So if you have a patient who has chronic vitritis or pars planitis, what may look like, but behind that vitreous haze, if you find yellowish white patches in the choroid retina, or if you find a diffuse haze beyond which you may see some yellowish white kind of reflex from the retina, or a cloud again with yellowish white reflex from the retina, then you should, or clumps of vitreous cells, then you should think of primary intraocular lymphoma. Retinal and sub-RP infiltrates look like this, and this is a high association with primary CNS lymphoma, and that's why we need to recognize these patients. These patients need to undergo a vitrectomy, diagnostic vitrectomy, with the sample adequately processed and appropriately processed. Otherwise, you'll miss the diagnosis of primary intraocular lymphoma. They also need to undergo CSF cytology and a contrast-enhanced MRI for meningeal lymphoma. The association is very strong. You can see that 40 to 90% of patients with primary intraocular lymphoma develop primary CNS lymphoma in about 10 to 30 months. So they need to be under constant follow-up for this situation. In retinal exudation, we have 3 or 4 lesions. If a patient has a macular exudation, the lesion may not be right at the macula, it may be somewhere else. These are 3 situations that I am showing. Each of these patients have a different type of exudation. This patient has an exudation with finger-like projections pointing towards the fovea, but you should actually look at the opposite direction to which this fact blood vessels are leading to, and that's a retinal capillary hemangioblastoma. So this patients can completely resolve of exudates. You can see that once the retinal lesion is treated with cryotherapy, exudation actually completely resolves. One more example of remote macular exudation because of a retinal capillary hemangioblastoma. That's a optic disc hemangioblastoma that can also cause exudation. So exudation is a feature of retinal capillary hemangioblastoma. One more lesion that can cause dramatic amount of exudation is vasoproliferative retinal tumor. This is a peripheral retinal lesion. It's like exuberant granulation, something like pyogenic granuloma in the conjunctiva that develops in the retina because of some retinal insult, which could even be photocoagulation, pars planitis, retinal cryotherapy, etc. One more reason for macular exudation with refractile kind of appearance is Coates disease. You can see peripheral retinal telangiectasia with macular exudation, which is quite refractile, and that's Coates disease. Now, this is nothing but chirpy, right? Chirpy can grow, and sometimes chirpy, which is absolutely supposed to be flat, can get some thickness. So chirpy can grow in terms of diameter, and it can also grow in terms of thickness. But as long as it does not have exudation, you have nothing to worry. The moment it starts developing exudation but without a feeder vessel, then you categorize it as retinal pigment epithelial adenoma. But the moment it develops vessels like this, then that is retinal pigment epithelial adenocarcinoma. So chirpy can evolve into retinal pigment epithelial adenoma and adenocarcinoma. Although it is rare, you should always remember that a retinal pigment epithelial lesion or a charcoal black lesion that is in the level of retina, not choroid, can actually be retinal pigment epithelial adenocarcinoma. So these are the masquerades that I touched upon: scleral pigmentation, sentinel vessel, sectoral iris hum, unilateral glaucoma in the young, granulomatous uveitis, hypopyon hyphema, lens coloboma and retrolental vascularized membrane, vitritis and retinal exudates. Thank you so much.
That was really extensive and interesting talk by sir, covering all the aspects of the masquerades of the intraocular tumors. Any questions? Anyone wants to ask, discuss?
Somebody left a pen drive.
Okay. We'll hand it over to them. So I would like to say that the time is also over and the session is concluded here. Thank you all for being patient audience and being here for the last session of the day. Thank you so much.